Welcome everyone, and thank you for joining us today. Please remember to put all of your questions in the Q&A box at the bottom of your Zoom screen. Thank you for attending AACP's webinar, Impact of COVID-19 on Futures of Sleep Medicine. Our speaker today is Dr. Deepak Shrivastava. Dr. Shrivastava is a sleep physician in California. He is devoted to medical education and research. Dr. Shrivastava is board certified in sleep medicine, pulmonary medicine, critical care medicine, internal medicine, and polysomnography technology. He's a professor of medicine, pulmonary and critical care at UC Davis and a teaching faculty at San Joaquin General Hospital. He's a senior faculty at UC Davis Sleep Medicine Fellowship Program. Dr. Deepak Shrivastava is a medical director of Sleep Disorder Diagnostic Center. He is an invited speaker at international and national meetings. Deepak serves on many boards and committees that provide guidance to the delivery of the healthcare. He is the chairperson for the Integrated Quality Council, an oversight committee that addresses the performance improvement and delivery of quality care to the residents of San Joaquin County in California. Dr. Shrivastava has lectured for dentists at numerous conferences on sleep medicine, as well as trained dentists in study clubs and webinars. He's also a published researcher and author of multiple books. And with that, I'd like to introduce Dr. Shrivastava.
Thank you, Jordan. At the outset, let me thank AACP for inviting me for this webinar. We are going through major crisis times in the world right now, and this topic that was assigned to me could not be better than what we have here is the impact of the COVID-19 pandemic on the future of the sleep medicine. We will go over a number of slides, and I would like to finish on time. I would like to answer everything that comes through. Today I'm going to cover, of course, do we really understand the full impact of the COVID-19 pandemic and what is going to happen down the road that includes all of us, both as the consumer and as the provider. So we'll be touching a few facts on that ground. We will talk about despite the pandemic and all the limitations that we had, there have been recent advances in sleep medicine and how it is going to impact the industry, and especially now in the changed environment of post-pandemic Disney days. We will also try to understand what's happening as far as the business trends are concerned in sleep medicine. So there is going to be a lot of information, and in a talk like this, many times you will see that we finish one topic and quickly jump to the next topic, and I have really tried to prepare diligently so that the information is flowing in a very smooth manner and connects with one slide to the other. So we'll see how that goes. So let's see what's up. We are going through COVID-19 pandemic and what it has done. So I thought about it. We all know what it has done, and there is no point in pondering over something which we have experienced firsthand for almost 18, 19 months now, and we really do we see the end to it. So we'll look at that and examine that where we are going. But one thing has definitely become apparent that we have poor access to health care across the board. People have been sitting at home and not being seen by their dentist or their other healthcare providers and so on, and are getting worse. Even if they do not get COVID-19 infection, they are at risk for a variety of diseases, including the dental problems as well as the medical problems. And we'll talk about the common problem, which is the next one, the sleep apnea pandemic. Just before, in December of 2019, we began to see the cases of COVID-19. We already know that for years, we have been dealing with this pandemic of obstructive sleep apnea. And how bad that pandemic is, we'll examine a little closely. At the bottom, you can see these slides are sequential here, the COVID-19 pandemic slide, and we will expand on this slide because this is of our interest, that what is the prevalence of diagnosed and undiagnosed obstructive sleep apnea. We'll talk about that pandemic. Then we'll switch on to obesity pandemic. We'll not spend a lot of time on obesity pandemic. However, we know that what's happening with the world. We have become a 24-hour society. Our habits are changing, and we are becoming more and more sedentary with the cell phones and the social media that continues to engage us regardless of what we do. The physical activity is going down and our diet, exercise, and sleep are suffering, and we do make negative lifestyle choices. The obesity is prevalent and worsening across the world, including United States. And then last but not the least, let's talk about the most dated and chronic pandemic of sleep deprivation. Guess when this pandemic started? This pandemic started years ago with the invention of the light bulb. So thanks to Thomas Edison to show us the light that we can see during the dusk and the nighttime. At the same time, what we have done to that resource is that we have become a 24-hour society. So we do not sleep. We continuously work. And now then we have the insufficient sleep. We have poor quality sleep. We have circadian rhythm disorders, jet lag, shift work, etc. And we'll talk about that briefly. So here in this map, I wanted to show you the prevalence of the sleep apnea that we know. And if we will go over here, you can see the United States, if we combine these both apnea, hypopnea indexes here, you can see 54 million here, 24 million here, France, Germany, Brazil, Nigeria, Pakistan, India, Russia, Japan. I added up, all of this comes out to be about 500 million. So the 500 million is 500 million of the population. And then you look at China. Add China. China itself is about 250 million sleep apnea cases. So add is 3/4 of a billion population that we know of is suffering with obstructive sleep apnea. Guess what we do not know? What we do not know is that this 500 million is considered about 10%. So, it exceeds. And my bias, here is my bias. My bias is that unless proven otherwise, everybody has a sleep disorder breathing. Now, what's the extent of it? So I argue that when we look at this AHI of 5, on every box here you see AHI 5 is considered. What that means? That means that if you have 5 events or more every hour of sleep of apneas or hypopneas together, then we say that you have a problem. What about if you have AHI of 4 and your oxygen goes down to 80% numerous times at night? You add up that numerous time, it adds up to be more than 5 minutes of oxygen saturation below 90%. You have significant oxidative distress, but AHI is 4. What are you going to do about it? And that's the challenge, because we have a cutoff, scientific cutoff. I always used to chuckle with my teachers that how did we get to this AHI of 5, and they always joked around, but we researched and turned out that in the big sleep heart health study, they studied that when AHI reaches 5, there is an exponential increase in the cardiovascular, neurocognitive complication, public health hazard, metabolic complications. So there are a lot of complications that tend to occur with AHI of 5. But again, my bias is that AHI of 4 is no different. It's just that we look at things because we are studying AHI by way of sleep study for one night. What happens to the second night, I don't know. What happened last night, I don't know. So this is a huge problem. And there are a lot of cases. And as you can see the map here, here's United States, but areas of the world where we don't even have the data. So once you add it up, I think my bias is correct that unless proven otherwise, everybody has sleep disorder breathing. Okay, so what's going to happen to COVID-19 as we talked about? So there are a few countries, here is Portugal, which are way ahead of us in terms of when they had COVID-19, when they started vaccinating, what's their vaccination rate, and what's happening to those countries. And we can learn from there, and actually CDC does. They monitor every part of the world. So the pandemic became endemic. Well, what's the difference? The pandemic is you have lots of cases and very rapid rise of cases over a short period of time. A lot of population is sick and dying, as we know already. But then there is this underlying tone where there is a slow and steady presence of that disease, in this case COVID-19, which just continues and does not tend to go away. So how does that happen? First of all, we know that if you have herd immunity and majority of the population is going to be vaccinated, the minority of the population which is not vaccinated is not going to get the disease. Well, it is turning out in terms of the COVID-19 that that may not be the case. Almost the whole population in Portugal is vaccinated, yet virus is still circulating. So here in United States, we can always say the people who are not vaccinated, they are responsible for all these new mutants and variants which are coming, and they are the ones, because of them, we are unable to get our arms around this disease. But that may not be the case. It's just the nature or the natural disease characteristic that the pandemic is now becoming endemic. So very likely that in United States and likewise in the rest of the world, the virus will never be eradicated and it will become endemic here in United States as well. What that means to us? That means to us that we have to be on our toes and we have to be prepared as a specialty, sleep medicine, whether we are medical doctors or dental sleep providers or surgeons for that matter. The reproduction number of COVID-19 has come to about a median of 5.7. That means one index case, somebody who is infected with COVID-19 is likely to give it to 5 or 6 people. So that's called the R number and something to look at. That R number should go down to pretty much 0. The index case gets the disease and then they get better. For example, non-infectious pneumonia, if you will, pneumococcal pneumonia. It's treated and rest of the family members who are in touch with the patient, etc., they are exposed, but they don't get the disease. And nobody is going to make that announcement that now this is the date, tomorrow onwards we are into endemic. It's just a natural progression into that. There has been talk about there's an association between the high risk of OSA, its comorbid conditions, and risk of COVID-19. So yes, we know and we fully understand that obesity is a risk factor for COVID-19 infection, but OSA itself may increase the risk of severe COVID-19. This is just latest from Sleep and Breathing, 2021 data. They had survey, pretty robust sample size, 26,000 respondents, 77% male, and they ignored the obesity. So BMI came out to be 24 plus minus 5. So they kept the normal body weight because obesity is now a confounder. So we would not like to include that in our database here. And mean age was not elderly, which was considered to be at high risk at that time of this study. So they went with younger middle age, 41 onwards to 50, 56. And then they looked at the prevalence of OSA. Well, the high risk of OSA is, so if somebody has obstructive sleep apnea, they're going to have almost 1.7, or you can say for clarity, 2 times the risk of developing COVID-19 infection. We cannot afford that in the setting of a disease which is treatable, at least manageable if not treatable. So if the patient who has obstructive sleep apnea and develops COVID-19, they have very high risk of hospitalization and ending up in the intensive care unit. On top of all this, what happened was that Philips Respironics went ahead and announced because they found some people complain about that there is something in your machine which is causing our airway to get irritated and things like that. So they started looking at it, and then what they found was very impressive. They found this polyester-based polyurethane, that foam that they use to temper the sound that comes out of the CPAP, BiPAP machines. So they studied it a little more and they said, well, it is off-gassing certain chemicals, and scientists said that it could potentially lead to cancer. Well, of course, we don't want to hear that. So they became a little more proactive and decided to recall all their CPAP and BiPAP. So now we have a pandemic. We are saying and suspecting, of course, lack of time, we cannot do a randomized controlled trial. So whatever data we have is very supportive that obstructive sleep apnea is a risk factor for COVID-19. And now we are going to take away the CPAP and BiPAP, which is exactly what happened across the country, across the world, from the people who already had these machines and had the diagnosis. We do use a lot of procedures in the hospitals, in the facilities, in the office, open section of airway secretion, sputum induction, when we are doing CPR, when we are intubating people, extubating people, or doing bronchoscopies, in your dental office, when you are using the ultrasonic scaler, high-speed dental handpiece, air water syringes, air polishing, air abrasion, all sort of techniques that we use, they generate aerosol. And all of a sudden, everything was put down. I wrote this article. This was the title, The Ventilator Crisis, Panic Mode and Sensibility. The link is here if you would like to look at. Now, there is a follow-up article which was published by Springer in their journal, Sleep and Vigilance, in June. Coincident with Philips Respironics announcement, and these were the first couple of articles, as I believe, that anybody had written. So we have to look at the alternatives. If we are not going to be able to use CPAP, BiPAP, by the time FDA is going to fix the machine approval and all of that, and machines come back into the marketplace, we are out of business. So you can do our familiar terminology, UPPP, or make the size of the tongue smaller. You can do much more involved major procedure, do the MMA or maxillomandibular advancement, or you can do something like upper airway stimulation therapy. You have seen this picture before. This is the hypoglossal nerve stimulator, which is an alternate treatment, but it is only considered and approved for mild to moderate sleep apnea. The success rate is about 60% in the right setting, and it does work, about 70% reduction in the apnea-hypopnea index. So it does not cure it, but it cuts it back significantly in a susceptible individual. And of course, we come to our favorite oral appliance therapy. We have a lot of experience. Well, for how long? Almost 20, 25, 30 years in the context of sleep apnea, almost more than 20 years of experience. We got the end-to-end digital processes. We can make very precise designs, and we have a number of custom oral appliances that we can make. Well, do we know how long it takes? We all know how long it takes to do all of that, 2 to 3, 4 months sometimes, And it does improve compliance and overall sleep-related outcomes. Compared with CPAP, we know all of that science. However, we have to do it quickly. So here is the role of temporary or the provisional oral appliances during the COVID-19 pandemic. American Academy of Sleep Medicine, Dental Sleep Medicine came through and made some recommendation in this regard. A few other people look at that. And of course, yours truly went ahead and wrote an article about it, which is in the press, and you'll be probably seeing it. But the interesting therapy, and I suggest that despite my webinars and publications, I have not seen a lot of activity. And the limitations may be the gap between the provider and the patient, and people who are sitting in that gap, the payers. So who's going to pay for it? And it is not approved by certain insurances, etc. So because of that, we are having a lot of problem. But many of these appliances could be cheaper and can be fitted at a cheaper cost. So I am definitely suggesting to my patients to go see the local dentist and come up with a plan where even if they are going to pay out of pocket, they will protect themselves from the complications of untreated sleep apnea. All right, so what else can we do to improve patient care for OSA? We talked about 4 pandemics running concurrently and risk of obstructive sleep apnea and so on. So there are about 5,700 board-certified sleep medicine specialists in the United States as of 2019. There are 84 fellowship programs in the country and 180 training slots. And not everybody has 10 or 15 slots. Some have as low as 1 or 2 spots. Others may have 10 spots. So there is very limited people who are going to the training. To make it worse, almost nearly 45-50% of the medical schools actually do not have any sleep fellowship programs, let alone teaching the medical students. As you have always heard, medical students still receive about 4 hours of education and 4 years of schooling. So the new sleep physicians which are being produced from these 84 programs, they are not enough to replace the physician attrition who are retiring and otherwise not working. And then, of course, just like any other specialty, the distribution is definitely uneven. So what do we do in a situation like this? So American Academy of Sleep Medicine went ahead and put together a large group of different organizations. And of course, I saw a lot of discussion about oral appliances and dentistry, but I did not see a representation of dental organization in that, or maybe they were there, but they were just not identified as such. But this paper published and talked about the recommendations and observations of that group. And of course, dentists and dental sleep specialists were identified as a group that they can go ahead and screen the questionnaires to identify the patients with high risk of OSA. What's new about that? Nothing. We've been doing it for a long time. And then you refer the at-risk patient to medical provider. Well, nothing different. We've been doing it. It's nothing new. Dentists with expertise in dental sleep medicine can provide oral appliance therapy for OSA, and they need additional education such as differential diagnosis training. Many of you who have been in conferences, etc. with me, I give a lecture, the things that you really don't need to know, but it helps you solve the very difficult cases. And I talk about other things, insomnia, circadian rhythm disorders, restless leg syndrome, that will actually defend you. So you have made a great appliance and it is fitting. You did the sleep study after the appliance and apnea hypopnea index is down to normal, if you will. Patient comes back and says, "Doctor, I'm still sleepy and your appliance has failed." Sleep specialist says, "Oh, well, I don't know, you were not tolerating CPAP and now this is also failing," but nobody is looking at what else may be causing sleepiness. And that's the talk. So they do recommend that differential diagnosis, and I suspect that you are a sleep specialist in your own accord as a dentist. You should know the entire spectrum, even if you are running back and not doing the whole yard of the game, but you have to know the game plan, who is doing what and what else is involved. So this is a very important point, but we've been doing it. And then, of course, we've been singing this song, unfortunately, of collaboration and multidisciplinary and so on. And there's nothing new that I thought that given the pandemic and all these risk factors, what can we do? Standardized education for partner provided, details rules of engagement, but nobody is talking about what to do with the patient tomorrow in the morning when I go to the office. So here is the cartoon where you can see the California here, Texas here, Florida here, some few other states. This is the distribution of the sleep specialists in the country. So if we are going back to refer all these patients to medical provider here, where are we going to refer the patients who are in this area where there are only few sleep specialists and they may not be approached? Think about telemedicine. Think about plan. We have to start thinking about things that we can outreach, and that technology is available that is acceptable by the insurance company, etc. You still have to have licenses in these states to practice. Just cannot have a telemedicine service without the licensing. So what can we do? Again, the same group under the COVID-19 lockdown. Unfortunately, if you remember the CDC grading, and dental offices were actually called non-essential treatment, and they said, well, when the lockdown comes, we have to close the dental office as well. So it should not be non-essential, and I encourage that talk to your organization, etc. And in any crisis, healthcare crisis, especially one like this, the dentistry is essential service, not non-essential service, and I wanted to make a point about that. By the time the dentist sees the patient, they spend a lot of time doing this. Consult, PSG, titration, get used to CPAP, fail the CPAP, then finally they will find somebody and then send the patient. So telemedicine is a good resource. I think every dentist should start looking, if not already doing, should start looking into that. And of course, think about these temporary provisional appliances to use, and see how you can develop a business plan which will be suitable to the patient and to your pocketbook as well. And this group agrees that dentists providing oral appliance therapy during the pandemic have an important role. I couldn't agree more. So we have to do something about this. So changing the gears, let's say that you have your patient, you have a provisional appliance, you switched 3 months later to the permanent appliance, patient is happy, your sleep study showed that AHI is normal, but they are still complaining of sleepiness. Sleep specialist says that they have no other sleep disorder. So there is a certain percentage of patients, 69%, even if they are treated for obstructive sleep apnea with, let's say, CPAP or oral appliance, they will still feel sleepy. In old times, we used to give them the Provigil or modafinil. And of course, as a dentist, you really have to check with your state dental board that is it in your scope of service to prescribe these medications or not. So that's a very important point I wanted to make. Having said that, there are a couple of drugs which are now available. Sunosi is here, which is now approved for treating the sleepiness related to treated OSA, the residual sleepiness. And it's nothing but it's one of those dopamine agonist and the norepinephrine reuptake in SNRI, excuse me, that's what I want to say. Selective norepinephrine reuptake inhibitor, SNRI. So what it does is it won't be taken up by the receptor, so there is increased norepinephrine in the receptor site that will be adrenaline rush, will keep you awake during the daytime. So that is approved. There was a trial done here, parallel arm, rather than going into details, very nicely done trial, but they came up with a dose 150 milligrams, and it improved the Epworth sleepiness scale and also the maintenance of wakeful time in the studies. Some side effects which you would expect: nausea, lack of appetite, anxiety, and slight increase in blood pressure. In hypertensive patients, you want to be careful about increasing their blood pressure too, because it's epinephrine or norepinephrine, what is we call levofed. So the drug is there, an alternative to the modafinil, which is known to have a side effect of headache, and some people don't tolerate it. Remember, these drugs are given during the daytime, not the nighttime, because I've seen that mistake. You will keep the patient up. There is another drug, pitolisant, for the same thing, for residual daytime sleepiness. It reduced the daytime sleepiness, improved the proportion of responders, 71 versus 54%. So it's a good drug. It can cause headache and insomnia, but there are no serious cardiovascular side effects. The data definitely needs a little more replication, and this should be coming in through the FDA soon. So there are a couple of extra drugs available. If your friendly sleep specialist does not know, then you can advise that there are a couple of medications. All right, so let's look at the non-positive airway pressure interventions, what we can do. You have heard about leptin and ghrelin. Ghrelin is the hormone that is high in stomach when we are hungry, and when we start eating, then leptin levels begin to rise, and it satisfied our satiety. That means at some point we say, I cannot eat anymore, or I'm full. That comes with the leptin. People who are morbidly obese, they have what is called the leptin resistance. Their leptin level is high, but they are so resistant that they don't see, and the leptin levels do not translate into satiety. And that's the problem. So this is a balance, counterbalance of how we eat. But this leptin deficiency can also increase the inspiratory flow limitation. So there is this nice study from 2019, and it also impaired hypercapnic ventilatory response. What is hypercapnic ventilatory response? If our CO2 goes up or oxygen goes down, or ventilation must go up. That's normal physiology, to blow off the CO2. So, but if you're deficient in leptin levels, then you'll mimic what would be called the obesity hypoventilation syndrome. That means even during the daytime, you will be hypoventilating, your CO2 will be going up, and therefore oxygen will go down, and then you will have all sort of problems, including hypoxemic distress. So both obstructive sleep apnea and obesity hypoventilation syndrome are common in obese people, and they have high levels of circulating leptin. As I said, they just have resistance to that leptin and they keep eating and cannot control their body weight. So these guys, the authors here, they went ahead and tried on the mice actually intraperitoneal leptin and intranasal leptin. And what they found was that intranasal leptin improved the inspiratory flow limitation by 0.5 milliliter per minute. So that's a great deal of increase in little mice. So if you translate that into humans, that will be a wonderful, wonderful increase. So a non-flow limitation, the general ventilation where there was no flow limitation, they had no sleep disorder breathing, the ventilation actually went up by 40%. So this is a great breakthrough. Well, in humans, of course, we're not going to be able to do intraperitoneal, probably very unpleasant, I guess, but intranasal is a great possibility. So we'll be on the lookout for this intranasal leptin and see if that can be used in many of these patients to improve their flow limitation and reduce their hypopneas and apneas. The other combination is atomoxetine and oxybutenein. Oxybutenein, you know, in the context of nocturia and things like that. So they started looking at these two combination, and we'll go over this picture in the next slide briefly. So what happens is that in sleep apnea, we all understand, but just to review, the tongue begins to lose its tone. Which is a major upper airway dilator, and that is, as far as our current understanding it, that is the source of the pathogenic mechanism of obstructive sleep apnea. And there are two major contributors to this impaired activity. One is withdrawal of the non-adrenergic drive during the non-REM sleep, and active of muscarinic or cholinergic inhibition during the REM sleep. So, you know, the acetylcholine here and noradrenaline here. These are the two neurotransmitters that we study when we are studying the basics of sleep. So this combination leads to the impairment of the tongue, and therefore we develop the obstructive sleep apnea. Well, when these authors used the combination of these two medications, they were able to lower the apnea-hypopnea index by 63% from a median of 28 events per hour to 7.5 hours. So that's pretty good data here. And their oxygen saturation went up by 8%. So that's wonderful. We lowered the AHI, if we think the AHI is gold standard, which we can argue, and the oxygen saturation, which is really important because of the oxidative distress. So looking at this, there is more studies going on to see what happens to the loop gain and arousal threshold. But if we look at this graphic here, this is very interesting. Here's the combination, here's the placebo. These are two drugs independently and in a combination. Okay, so here the line here is the effect, and this is the confidence interval up and down here. So look at the combinations. As opposed to placebo, the ventilation improves way up here, whether it's active or passive. So with the obstruction, without the obstruction, combination of the drugs is definitely improving the ventilation. You look at the arousal threshold. So we know that if arousal threshold is high, then a person will continue to sleep and not wake up and will suffer through the side effects of oxidative distress. Their apneas will be long and continued because once you wake up, then your airway opens. This combination drug here, it actually improved it. So from as opposed to the, but there's more studies is still being done on that. We also know high loop gain is not good. So the vigorous response, we need a lower loop gain in order to counteract the effect of this obstructed airway. And here is a signal, definitely lower than the placebo with the combination of these two drugs. And of course, look at the AHI that has gone down by 68%, 63%, I guess, from here, this high level down to less than 10%. So clearly the signals here and the data here is very compelling. We will change gear again and now look at some of the new thinking that what happens with the microbiome. the obstructive sleep apnea, and there has been these studies there for some time now. They look at the nasal bacteria and the biomarkers related to that. In the severe OSA, they noticed that there are distinct microbiota and a lot of inflammatory markers. So you can measure these inflammatory markers. Now they are doing the breath analysis, secretion analysis, etc., to look at the biomarkers. And based on that, they are deciding that which patient is at risk for what condition. So this science has a lot of potential, as we will see. Increased inflammatory biomarkers and no microbiota composition change after 3 months of treatment with CPAP. So you can use these biomarkers and a microbiologic profile from that area and predict what will happen with what treatment. So this science is in the infancy, but it seems like that there is going to be an application coming through very soon. So further studies are needed, and there are a bunch of what you would call is the confounders is still that we have to work with. For example, acid reflux, and that brings the different flora to your nasopharynx and so on. So severity of the OSA is correlated with differences in microbiome diversity and composition. So when you go to the conferences now, you will probably hear about the nasal as well as the gut microbiome. So nasal microbiome of subjects with severe obstructive sleep apnea have Streptococcus prevotella and Veillonella. So these are the organisms which are there, and we will have to have quantitative data. We just cannot go by the qualitative data in these things. But nasal microbiomes differences were associated with inflammatory biomarkers. So we can use these biomarkers and go back and see what kind of microbiomes are here and how they are associated with the disease and how they change in response to the treatment. Okay. So here in this cartoon, you can see, I apologize for the poor reproduction, but in the healthy nasal cavity, we all know there is a Staphylococcus, there is Corynebacterium, Moraxella metacensis, etc. If the person has chronic rhinosinusitis, then Staphylococcus, allergic rhinitis, there are different biomarkers for allergic versus infectious. And so nasal cavity now has become focus of research. So either there is going to be symbiosis, so that the host, which is the person, and the bacteria, which are called the normal flora, are living in harmony, versus there is dysbiosis. That means disease is causing them to go in different direction, and now they become a marker of the disease. And then to counteract with it is number of things: how the child is fed, the birth mode, what is coming through the sibling, what's their genetic history. Smoking definitely has significant role, and use of the antibiotics, etc. So we'll see how this science is going to play out, because it is expanding now into the gut. And there is a lot more studies on gut microbiome and sleep now. It affects our circadian rhythm through the brain, intestine, microbia. So circadian signal, you know that it is everywhere. Every cell of the body has its own circadian rhythm. So feeding and fasting, we just talked about ghrelin, leptin. Hunger time, you eat at a certain time, you go to the bathroom at a certain time. And we just talked about all these microbiota substrate. But they have different pathways. Of course, circadian goes through the solar system, and sleep-wake system affects the brain, and then has the physiologic effect of metabolic homeostasis, because the circadian rhythm controls every system in the body. Then we have the gut, which is affected by caffeine, melatonin, different variety of foods, and then the metabolism of nutrients changes here. And gut bacteria are now considered the missing link in this whole scheme of things. So the focus is here now. And clearly, same thing, microbiota. The microbials have their own rhythm, chronobiology that we talked about. So and then they participate with metabolic syndrome, etc., because of their own rhythm. So you can see that there is a complex science which is evolving. Here in the text, I have put the simplified things that Gut health has great effects on quality of sleep, so we have to talk about that with the patients. You have to have balanced diet. This is all related to circadian system, different organ involvement, different pathways, and their outputs. So my interpretation of this was microbiome of shift workers or uh, chronic jet laggers is likely in dysbiosis because they are traveling, their circadian rhythm is all over the place, and if they develop sleep apnea or sleep-related disorders, it has something to do with that. Hippocrates said all disease begin in the gut, so there's some wisdom to it. Also, just for the kick here, I guess, so you all know what serotonin is. 90% of serotonin is produced by these microbiomes. GABA, which is the major, most prevalent sleep inhibitory neurotransmitter, induces sleep. So, or benzodiazepine, or barbiturates, or alcohol, they are induce sleep by working on the GABA as an agonist, is secreted by the microbiome. So, there is a whole bunch of things that are affected by the gut flora. And if there are low levels of these, then there is more stressful situation and less chance to fall asleep if you have low GABA levels, if these bacteria are not producing. Gut also produces melatonin. So there's a whole bunch of things. Lactobacillus rich dairy shows if you consume it, better sleep quality. So maybe there is some wisdom to use those products in people who are not allergic to lactose. They don't have the lactose intolerance. And there are recommendations about the unprocessed food. All this material here, broccoli, artichoke, whole grain, banana, etc. So fiber-rich food. People always say fruit and vegetables. I like to say reverse it, vegetables and fruit. That's a lot better way to consume these products. More vegetables, less fruit. It still has fructose. Plants and herbals and probiotics and prebiotics. So there is sleep health and the gut relationship now that is developing and is going to be the talk of the town very soon. Let's quickly look at the novel predictors. So what are some of the new things that have come out that we can predict the outcome of obstructive sleep apnea? So one of the things that came out is the apnea-hypopnea duration. So you would intuitively think that if the apnea episode is lasting for 2 minutes, 3 minutes, that's really terrible. Well, that is terrible because now you have very long oxidative stress. So, and there is a lot of sympathetic excitation, the rest of the pathophysiology there with the on the cardiovascular system, blood pressure, blood sugar, etc. So if you have that oxygen saturation below 90%, there is a very high risk of cardiovascular disease and the death in obstructive sleep apnea. But now if you look at shorter events, and that they may be very important too. What shorter event means? That you are getting obstructed frequently and your oxidative stress in total may not be as high as your sleep fragmentation and you are sleep deprived. So these guys started the group looking at them, and they looked at about 6,000 people, and a third of them had quite a bit of apnea-hypopnea index, and then they started looking at, they made the 4 quartile. The shortest quartile of event duration, that means their episodes of apneas and hypopneas will last only for about 16 seconds, versus longest duration by their definition was about 30 seconds. So they have the short apneas and long apneas. And the short apneas exhibited a 31% increase in the mortality, not even morbidity. So you can imagine that what impact this short duration apnea hypopnea can have, and it can actually predict mortality based on this data. So it could reflect so many things. Somebody has low arousal threshold. That means little thing will disturb them and little obstruction will wake them up. So of course they are protected from the oxidative distress, but they are not protected by the sleep fragmentation and then resultant sympathetic tone. Somebody wakes you up all of a sudden, or alarm all of a sudden, you can wake up with the tachycardia. That's a sudden sympathetic drive. So there is this phenotype that we need to start looking at, that if they have low arousal threshold, if that's the case, you can use hypnotics so that their arousal threshold is increased, or use oxygen so that they do not suffer with oxidative distress and things like that. Though jury is out, we still don't have clarity on these things. So risk may not necessarily stem from just shorter apneas, but it will be the other factors like low arousal threshold or loop gain that will predispose to the arousability and therefore the morbidity. So we'll see, but this is a very interesting observation, and I thought that I'll bring it up to this forum. Also, they started looking at symptom subtypes. So they, in this particular study here, they put the 3 clusters of OSA patients based on the symptoms. So people who have disturbed sleep, insomnia, I cannot fall asleep, I'm waking up through the night, or somebody has sleep apnea but say, hey, I have no symptoms, I'm fine, I'm not sleepy during the daytime, yes, but the AHI is 56 and desaturating, but no symptoms. And third is, well, they have an AHI of 6, but they are falling asleep when driving and so on. So they put them into this group. And this group, the cohort was taken out from the sleep heart health study with AHI of again 15 plus. People with disturbed sleep 12%, minimally symptomatic status 24%, moderate sleepiness 39%, excessive sleepiness 17%. So they concluded here that excessive sleepiness subtype had increased risk of cardiovascular disease, and hazard ratio is almost 2.5 compared with 3 other subtypes. So, and therefore, if you will go back and say, once the patient has apnea hypopnea index somewhere between 5 and 14, you have to show the symptoms, and one of the symptoms is they have to be excessively sleepy before the insurance will cover their treatment, and that probably comes from this kind of observation. So this finding suggests that sleepy phenotype may be a surrogate marker for cardiovascular disease specific to obstructive sleep apnea. And clearly then we have to treat their excessive daytime sleepiness with the oral appliance or the CPAP. Okay, there are some of the physiologic traits, and we are coming to the end of this, that will show the response to oral appliance or upper airway surgery. We know hands down that oral appliances improve AHI, daytime sleepiness, blood pressure in patients with OSA comparable to CPAP. But the therapeutic response is highly variable. You really don't know that how to predict which one. We know which patients will be suitable patients for therapy, but whether they will respond or not is very, very variable. So they started looking at some of the physiologic traits: pharyngeal collapsibility, muscle compensation, loop gain, arousal threshold. Remember, these are the phenotypes of obstructive sleep apnea, are well accepted signs. So these guys actually looked at both the responders and non-responders, and the PSG is in 92 patients with AHI of over 20. And what they found was that greater efficacy of oral appliance therapy was associated with weaker pharyngeal muscle compensation and moderate collapsibility. So mild and severe collapsibility did not make the cut, and the moderate collapsibility, well, we have to really find out how we're going to measure all of that. Favorable non-pharyngeal traits were if the patient has lower loop gain as opposed to the high response, high loop gain, and higher arousal threshold, then they were the suitable candidates. So here is a group of at least 3 phenotypes that are suitable candidates for oral appliance therapy with possibility of predictable response. The predicted responders showed residual AHI of 8 versus non-responders which were almost twice as many, 16 events per hour. So routine clinical markers like patient's age or neck size of 16 inches, 17 inches in women and men, the PSG data, AHI or ratio of the non-REM versus REM AHI, actually that did not predict the response to oral appliance therapy, but these phenotypes did. So there is a promise for personalizing this OSA treatment with oral appliances as we figure out more that how can we identify these features. And many of these features can be actually identified through the PSG. You just have to know how to do it. And We don't have time, but that leads us to the next topic. So that next topic is that right now what we do a lot of hard work. Patient sleeps overnight in the lab, or a machine is placed on their arm and chest, and a sleep technician is scoring it. It's all manual visual things. But now machine learning technologies are available for long time. We are using this, the artificial intelligence for speech recognition, smartphone, home speakers, everywhere, self-driving cars. I mean, if we just go on the examples, we can spend the rest of the time with examples. But the fact is that AI is part of our life, and how best we can use it to our benefit, to the benefit of our patients. So if we use the machine learning tools and screen patients, the very superior prediction model can be created with very high sensitivity and specificity, even if for AHI of more than 5 events per hour. So we do have that. The challenge is how to do it. This is all at a point where there's a lot of research, a lot of talk, but we have to have translational science bring it into the clinical practice, and which is what is happening. Now, we know that there are sensors that you can use in the bedroom. There are all sort of products which are available, apps are available to study your sleep, and so on. So American Academy of Sleep Medicine has some guidelines, and we'll finish with those 2 slides. But we all know about these things: bed sensor, smart watches, ultrasound, your cell phone related thing, radio frequency signals, wireless EEG. All of these steps are already available. I have worked with so many of these and experimented with these, but unfortunately they are giving the same simple data about the sleep. Nobody is able to, with high specificity, able to discriminate between REM sleep, non-REM sleep. So they are looking at the movement, they are looking at the breathing, and whether you are awake or asleep based on if you are moving or not moving. So you can lay there awake and they will say you are asleep. So we do have a little bit of problem with the accuracy. So here, if we look at the accuracy on this axis and user burden on this, of course, polysomnography has a lot of burden, but accuracy is pretty high. Versus if you just use the sleep diary, well, very little burden or less than this, or bed sensors, no burden. It's in the bed and you just sleep over the bed, but then the accuracy is much lower. So eventually we have to find a common ground where we are here. Accuracy is very high and user burden is very low. Hopefully we will come to that point with R&D that is ongoing, as a matter of fact. And I also ask my audience here tonight that just don't think within the box. Continue to think, be agile and agitated, and think that what you can come up with in terms of this technology. There are predictive power and noise among these things. I'll quickly go over. Performance matrices: sleep time, sleep quality, sleep stage, sleep disorders, scalability, usability. If you look at that, here's the sleep diary. You cannot make sleep stages with the sleep diary, but polysomnography will give you accurate sleep time based on the sleep stages, etc. Or the bed sensors are very useful. So if you look at that, some of these are really strong and some of these are really weak. Most of them fall in between. So we really don't get a good quality data still as of today, other than from the polysomnography or type 1 or type 2 test. Type 3 test is still not there where we would like to have it, the home sleep testing. So artificial intelligence has been there for a long time. As you can see, here's the timeline. It was supposed to show the number of years here at the bottom, but I guess it's all in 1900. Artificial intelligence is basically a program that can learn, adjust, and perform human-like tasks. So we can program it and it can do it, but it gets better if machine learns. And you and I have experience in this. You talk to your friends about that you want to buy a dress shirt, and within hours or minutes, you will see that your cell phone is now sending you advertisement for dress shirts. So this is the machine learning. This listens to you, catches on the keywords, and then it will go ahead and react. And the deep learning is the program that learns complex features in a supervised and unsupervised manner from structured data. So as we go higher and higher on this spectrum, eventually I would like to say that AI is going to take over most of it, freeing up our technicians from the lab, freeing up our scorers from manually screening the sleep studies, staging, etc. And there's right now, as of today, the correlation is almost 85%. So if you go to American Academy of Sleep Medicine, and they have a program called Interscorer reliability, 85% is the cutoff. And with your machine scoring and human scoring is also 85% concordance. So there is nothing wrong. Yes, that 50% could be something we can talk about some other day, that what we can miss. So American Academy of Sleep Medicine has come up with a position statement here that electrophysiologic data during the PSG is well suited for analysis using the AI. Goal of AI integration should be to augment, not to replace, expert valuation of sleep data. That means it should be monitored, at least at this point. We have to have a lot of guidance for logistics, data security, ethical matters, and legal considerations in this scheme of things. We can definitely use massive quantity of physiologic signals we do about 5 million PSGs and about 25 million sleep-wake EEGs in United States only. You can imagine how many trillions of data points we create every year. And all of that data cannot be manually handled. So with AI, we will be able to handle that kind of data and come up with better clinical impressions. So they talk about improving the patient care at the end of the day. AI will allow clinician to extract greater insights from the PSG. PSG only gives what they give is the AHI or desaturation, or if you are astute, you are looking at some EEG findings, arousals, etc., or leg movements and similar things. So our metrics that we really use are very few, which we contain in our sleep reports. But there is a lot more hidden in that data, in those waveforms, and those waveforms can be really utilized using the artificial intelligence. So that's where it is going. Of course, pitfalls will exist in any system, and the smartness is to find out and ignore and avoid. I'd like to finish with homage to these two legends of sleep medicine, Dr. William Dement, who has since passed away, known as father of sleep medicine, his famous book here. And the reason we are talking about AI, this is his lab, and this is a sleep machine. It's the GRASS machine. I trained on this very machine at Stanford when I was working with him. And now we have come this far that we are talking about AI and deep learning and so on. And here is my guru, Dr. Christian Kimanov, who has also since passed away, and has this Christian Kimanov Young Investigator Endowment Fund. I encourage everybody to participate and contribute to his fund. He is or was a pioneer in sleep medicine, who first described obstructive sleep apnea syndrome, co-founded the General Sleep, which we all read, and helped establish the Stanford Sleep Medicine Center. And he is my guide. And here he is driving me somewhere in San Francisco. He said, "You have ideas." This is a quote from 2017. "Check them, test them, and see if they are right. That's the only thing that we can do. We have to advance the field. We are in the 21st century. You have to take hold of the flag. Thank you very much, everyone, for all you have done. The future is yours." And I would like to close with that. Thank you so much for listening.
After treatment, sometimes the AHI does not significantly improve, although the patient reports feeling better and their bed partner also notes improvement. Do you think another metric besides AHI should be used to evaluate if the OSA level is improving/worsening?
Yeah, that's an excellent question. In current scheme of things, AHI is considered the gold standard, and many of us believe that there could be a better metric that we can measure. Unfortunately, we do not have the technology right now to do those kind of observations. So our second one is how much oxidative stress the patient has. So that means their oxygen saturation is going down to less than 90% for total cumulative time of 5 minutes or more. And that definitely causes significant cardiovascular impact. We can definitely look at that patient that AHI is still high, but they are subjectively feeling better. The question always comes up, why is AHI high if they are using, let's say, CPAP or oral appliance? Because during the titration, we titrate it to improvement of the AHI, not necessarily normalize it, but AHI goes down by a certain percentage. So let's say we agree that 50% of reduction in AHI is good. I have patients who weigh 300, 400 pounds. Their AHI is 80. And no matter what I do, BiPAP titration, what have you, their AHI is not going to go down below 60. Now, you still have 20% of the, on percentage-wise, it will be more, but 20 point reduction in the AHI itself, and that patient is likely to feel slightly better. Maybe their headache is gone or less, or maybe their blood pressure is improved by 2 points, something like that. But clearly, we have to continue to work with that patient. Unfortunately, at this time, we do not have some other testing that we can do and say, well, you are getting better because this X is getting better. So unfortunately, right now, we don't. In future, a lot of technology is changing. So what I mean, the current technology, you can use the watch pad like monitor, which does not go with the AHI, that goes with the pulse tonometry. So it looks at the events and then measures the sympathetic response to the event, and that's how they will calculate that how many events were there. So there is new technology coming, and of course, when it will become available, WatchPad is available. So if you want to go to alternate route, you can still use WatchPad, which is approved by Medicare and many insurances. But the cardiopulmonary coupling, there have been a few companies out there. Insurance companies have to support them, and that's one of the challenges that these companies run into. The lack of data or lack of enough data to the satisfaction of, let's say, Medicare or other third-party payers. That technology is available, it's there. It has just not hit the market because of the limitations of the way our system is set up. But WatchPad will be something that I would suggest that if you have availability and access to, you can try on that particular patient.
We have another question from Marlene Cornejo, and they say, is sleep deprivation something that can be happening in children too?
Okay, I'll start this with my bias. And well, there are few sleep disorders that they can occur, de novo when you are adult, etc. But the major ones that we talk about, the sleep deprivation, many times these insomnias, and especially obstructive sleep apnea, you have it. You have it right from the childhood. You probably have it when you're born because your anatomy is such as your genetics is predisposing. So you have genetic predisposition, you have morphologic, familial disposition, and also you have environmental disposition. So there is all sorts of things that will lead to sleep deprivation. And first of all, if you take an infant, if you take a toddler, they are not going to school, they still are not exposed to the social media and the electronics. They are subject to the parental disturbances. So the mom may be awake watching television. Well, if the child is, eyes are open and that wavelength light, which is blue light, pretty much is going into the child's eyes also, they're going to have the same effect, a very robust circadian shift in their sleep-wake cycle. And they are infants. They have no idea, but this is happening. So that's number one source of sleep deprivation that comes from their social activity, social engagement on the part of the parent. So that's the preschool child. Now you go to the child who goes to school. all of a sudden they are watching more television, etc. at odd times when they are supposed to be resting, sleeping. By the time they get hands on their iPad or cell phone, of course, you know the rest of the story with the electronics. So yes, that is true, that can happen. And then pediatric or childhood insomnia is very, very common. And especially if the child sleeps in their own crib or in their own room, not supervised by the parent, you can turn the light off all you want, but the child will lay there looking at the ceiling and not be able to sleep. And the time comes to wake up, then they are asleep and you cannot get them. So it translates into a lot of behavior issues and learning issues when it comes to the daytime. And nobody is looking at the nighttime insomnia on part of that chart, on the part of that child, excuse me. So yes, short answer would have been yes. The children can have significant sleep deprivation, which unfortunately goes unnoticed, and that's where the sensitivity has to be to really identify that what's going on in the child's life, especially if they are having behaviors and school problems or social problems.
How do you advise dentists communicate with and educate medical providers about our role in addressing sleep breathing disorders? Some physicians are skeptical about dentists' role or of oral appliances.
Education is the key, and communication is not our strength anywhere in any field. So that has to improve. Your credentials. So you are in any town, America, and you have your credentials, you advertise. I give a talk about the doctor-patient relationship, and this is what I recommend, how to approach these dentists. So you started your sleep dentistry practice, and you are screening patients. Some people are doing home sleep testing, I know, through whatever sleep specialist being used, but your neighborhood sleep specialist is not aware of your presence. And so one day you approach them, you call them or call on them, then or send in writing, email, somehow to open a dialogue with them, show them what you are doing. And this is the question, magic question that I asked. The Dr. Smith, I have started my sleep medicine, sleep dentistry practice, and I'm screening the patient. Not every patient is candidate for home sleep testing, and I would like to send you 10 or 15 patients every month. Are you willing to take that patient load? Well, if I was a sleep specialist and I have a lab and I'm paying my overhead, I'm very interested in expanding my business. And I say, once you have made the decision, you can go by the algorithms. I'm not asking you to send the patient to me, but if you send the patient, I'm board certified in sleep medicine, and once I have set up the appliance, here's the educational material if you would like, and then I'll have to send the patient back to you for making sure that the oral appliance is working and their problem is gone, AHI has improved, symptoms have improved, etc. So basically, you are not losing any business. And at the end of the day, this is all it boils down to. So I take that approach that is mutually beneficial, and in the middle of it, we are helping our citizens, our community.
They were just wondering if they could get your contact information, if there's any contact information you can provide.
Oh, okay. Well, my contact information is easily available. You can email me, you can text me. My cell phone number is 209-986-3663, 24/7. Everybody has it, and you can have it. Text me, call me anytime. And my email is, the personal email is Dr. Shrivastava, so Dr. and my last name, no punctuation, at comcast.net. That email is unique to me. I open it and I use it. So you're welcome to use it.
I want to thank you, Dr. Shrivastava, for the wonderful presentation, and thank you everyone in attendance today. And
thank you so much. I want to say thank you to everybody for uninterrupted attention. Thank you.
Yes, thank you, everyone.
Okay, bye-bye.